Hi, I'm Hank Meyer. I'm a pediatric pulmonologist from the Children's Hospital of Philadelphia, and have had a long-standing interest in taking care of patients with neuromuscular disease. And I have three colleagues who also have, well, four colleagues, including Reagan, who's a de facto pulmonologist. For any of you who know her, you'll understand why and how. I have three other colleagues next to me who four other colleagues, three other pulmonologists who have also been very interested and passionate about pulmonary management in patients with neuromuscular disease. And what Rachel asked us to do is come today and talk about general pulmonary management and then open the floor for any and all questions. So to my left is Oren Kupfer, who's from Children's Hospital, Denver Children's, to his left is MyMy, who's from Stanford. And then next to her is John Pascoe from University of Cincinnati. And then, of course, Reagan Foley, who many of you know. So I'll start with a couple of general comments. I think the most important factor in pulmonary management is recognizing that it's an issue and recognizing what things can foreshadow difficulty. Then related to that, understanding what is important to implement. I think in my experience, the single biggest limiting factor for patients with respiratory muscle weakness is inability to clear airways. You think a lot about ventilatory management and being on Bipap or being on daytime mouthpiece SIP ventilation, but I think the single biggest deficiency is inadequate recognition of the need for airway clearance. And I'll be happy to delve further into that, but I'll have my colleagues add further.
Hi, everybody. That's really loud. Sorry, I have an airway clearance problem too right now. Can everyone hear me okay? That's good? Okay. No?
On that side, it's hard to hear. It's a very big room and they're having
Okay.
a hard time hearing.
How's this? The speaker's right behind us, so it's really weird up here. So I agree with Hank. I think the biggest issue that goes unrecognized is airway clearance impairment and inability to cough effectively. As pulmonologists, we do a lot of different things to help people clear their airways, and many of our colleagues and pediatricians and internists don't recognize cough as a separate function from other ways to clear the chest. And so what I do is focus a lot on why is there an airway clearance impairment and how do we address that. And so there are many different ways we can do that, and be happy to talk further.
Hi, my name is Mimi Boo. I'm a pediatric pulmonologist from Stanford Children's Hospital. And I like to echo what Oren and Hank has already said. However, one of the things that a lot of families come talk to me about is, how do I know that my specialist who is taking care of me right now is doing the right thing? And so I think that what you're doing right now is important, coming to these national meetings to learn about the standards of care. And then for each individual person, you really need fine-tuning. And I think that what we want to do is to really partner with your local teams and on the national level provide more education, but be a resource. And so my background is I'm in medical education, and I think one of the things is that we want to be able to, we aren't able to clone ourselves and we can't be everywhere, right? And there's a small subset of pediatric pulmonologists who specialize in neuromuscular disease, but we want to spread the awareness that there is a resource like Cure CMD, right? That there is a website, there are care guidelines, and there will be more care guidelines on pulmonary care. And then to feel free to link your specialists to our group, or to look at the website and see, who in your region specializes in CMD, and connect with them and use them as what we call consultant in medicine. So doctors are really used to asking other doctors for help, and it's part of our practice. And so I think it's what's important is to remember that we are all here to help you as a patient or your child as a patient, and we don't intend to cause harm. So if something doesn't feel right to you, it's okay to approach us here.
And you're right, this is pretty loud. Okay, I'm John Pascoe from Cincinnati Children's. I'm also pediatric pulmonology, and I also do sleep medicine. So I enjoy watching kids sleep, which sounds weird, and look at lots of squiggly lines. But I think I might be the only sleep trained, maybe? Yeah. So I can talk a little bit more about that. And just out of curiosity, who, either show of hands or a head nod, who's had a sleep study or, yeah, okay. So you guys are pretty well versed. There are definite subtleties with neuromuscular disease and sleep studies, and part of understanding that is understanding the normal sleep too. So just to really quickly sort of cap that, and if I see people falling asleep, I know it's untreated OSA or or I'm just boring. So at any rate, so during sleep, we're regulating oxygen and carbon dioxide, right? And when we fall asleep, we lose our wake drive, so our carbon dioxide level goes up by a few points. During REM sleep, we lose muscle tone, except we're essentially diaphragm dependent when we're during dream sleep. And that's somewhat protective, so we don't beat each other up and hurt each other acting out our dreams. And so if you can imagine, if you have a weakened diaphragm, you're very susceptible to sleep disordered breathing. And you may not necessarily have signs of snoring. You might have some pauses, things like that, but it can be very, very subtle too. And so it's more of a continuum of starting in REM sleep and then going into non-REM as well, and then becoming full-time day and night. And so it's hard to recognize that initial part. And that's where I think we, as sleep docs, need to do a little bit more, and pulmonologists, in terms of trying to figure out what's truly hypoventilation in adults and children with disease, because the current definitions don't cut it by any means. It's caught much later than when we actually see it. So there's a lot of work that needs to be done there. And then in terms of what to watch for, I know a lot of people have already had sleep studies, it sounds like, but you won't necessarily hear snoring because you need to be able to create that vacuum to create the vibration in the upper airway. So it could be restless sleep, unrefreshing sleep, waking up with a headache, some daytime behavior problems. Those are all some sort of subtle cues that maybe a sleep study is needed. And also there's certain diagnoses within congenital muscular dystrophy that are more prone, especially with like SEPN1, LMNA, collagen 6. Some patients, children, they might be walking around and they're hypoventilating actually, so their carbon dioxide level's higher, but they're otherwise really functional. So there does need to be a little bit of index of suspicion as well there too. But that's the sleep side. So.
My name is Reagan Foley. I'm a pediatric neuromuscular specialist. I work at the National Institutes of Health with Dr. Carson Bonneman. And most of you know I'm very passionate about being proactive about pulmonary care, because as a neuromuscular doctor, I spend most of my time actually talking about the lungs, because if we get the pulmonary care right, we get mostly everything right then. So that's the most important thing for you to be able to lead your lives and to be happy and thrive and go off to college and drive cars and not have chest infections. And I've seen the effects of proactive pulmonary care be like really life-changing for our patients. And so I do spend most of my time liaising with pulmonologists, and I think the most important thing is meeting pulmonologists like this who understand your conditions. And we know, thankfully, the natural history of most of these conditions. So there's no reason to reinvent the wheel each time you go to the pulmonologist. We know the average age that Bipap typically is needed. So we have like a known formula. So I think when you bring that knowledge to your pulmonologist, and if he or she is open to listening to you, that's a good team. If he or she is not open to listening to you, then I hear about it, and Dr. Meyer hears about it, and we try to reach out. But I think the key thing is finding someone who listens, because then you have a good team going forward for your care. And it is very nuanced, but there's no reason to have to fight for Bipap. If any of you who know me, I always say Bipap is your buddy. The doctor taking care of you should realize when you need it and help you get on Bipap. second thing I always say is the cough assist. I call it the miracle worker, because that's the one thing that gets most of our patients out of trouble when they have a pulmonary respiratory infection. So those are kind of my 2 take-home points. But Hank knows very well that when any of you do have a trouble spot, we're often able to share that knowledge with you and your pulmonary team. But I think the most important thing is having a pulmonary team that is open-minded and listens.
Just want to make one comment before we open things up for questions and answers. Mimi mentioned care guidelines, and at the last CMD meeting, Rachel locked us in a room and told us to come up with care guidelines, which we did with some time after that, and she's edited and has put it into a format that eventually will be posted to the Cure CMD website. And then Liam Miller is actually using his technology experience to make an iPhone app or something that can be portable that you can take with you for care at institutions or environments such as emergency rooms where they may not be quite as familiar with what's necessary. So maybe Rachel can comment on the timeline at some point a little later, but that is coming. So I guess we'll shift over to asking questions and answers.
Hi, my name is Sarah Bloomfield. Our daughter Olivia is 7, Lama 2. I have 2 questions. First, average age you mentioned for BiPAP. I don't know if it differs by subtype, but what is that?
Great question. So for college and 6, we have very defined data on average age of initiation of BiPAP. There's a great series by Dr. Jim Collins, which is about to be published, looking at that. So in complete Marison deficiency, the data is based much more off of the forced vital capacity at the time. So I think what we typically say that once the forced vital capacity, or FVC, is declining towards 50%, but not yet at 50%, you should be beginning to have plans to initiate BiPAP. But for Lama 2, you're right, we don't have exactly a defined age. Personal experience, we have some patients have started BiPAP, but even at age 2 or 3 if it's needed. But by and large, more between ages like 7 to 12. But again, that's not defined for Lama 2. We need to kind of define that a little bit better, but it's mainly based off of the forced vital capacity as well as the sleep study in combination and the clinical picture.
My second question is about sleep study. We are due for one. It's been a little over a year. Sleep studies for us always feel like a total disaster. Yeah. Nobody sleeps.
You're not alone.
Okay, it's a horrible experience. We want to maintain, we want to maintain the information and keep on top of it, but we also question how well is she actually sleeping? How good is this data? Is there anything you can share on that, or any suggestions on how we can make these not so absolutely brutal?
Right.
So that everybody has to spend a week recovering from the sleep study that's supposed to help us.
It's really a misnomer. It's sort of a sleepless study, but I often have patients at clinic saying it was terrible, and I also have a lot of patients that say it was fine. But even though it seems like you don't get a lot of sleep, there's usually a good chunk of sleep that we can make some judgment calls on. And importantly, we get enough REM sleep, or that dream sleep, because that's where you're losing the muscle tone. In terms of if it's difficulty falling asleep or staying asleep, then there are some medications that can be used to help a child sleep, at least fall asleep, and maybe not necessarily stay asleep throughout the night, but falling asleep. So I would sometimes use Ambien even. It sounds a little bit crazy in that young age, but it is something to potentially consider, or clonidine, maybe a little melatonin. And those things won't necessarily influence the staging of sleep as much, and not necessarily the breathing aspect too. So there are some medications that you can potentially use for the night of the sleep study to give it a trial run. Child Life has been really helpful at our hospital too, in terms of helping to set up with the leads and everything, and not necessarily through the night. If there are patients who have significant behavior issues, autism, whatnot, then there are definite behavior plans that can be instituted throughout the night too, or sensory processing disorders. And so the other thing is, it's not a natural environment, right? Home is much better. And it's not, unfortunately, with the home sleep studies, we really, really need to monitor carbon dioxide levels. And we can't do that with home at this point. And then with kids, as I'm sure you've experienced, your daughter's probably tearing off leads maybe, or chest belts, or yeah. So at home, you don't necessarily have somebody monitoring to make sure that those things stay on. And then we also can't monitor the stage of sleep at home as well. So there's hopefully things on the horizon in the future that will make home sleep studies possible, but right now the in-lab is really the way to go. So I wish I had a better answer for you, but.
I just want to follow up a little bit further. I'm not a sleep-trained person, and I don't do a whole lot of sleep studies. I do them fairly selectively, and one of the challenges is that the vast majority of sleep studies are done for kids who snore who have tonsils, and so looking at obstructive sleep apnea. And one of the challenges is doing an interpretation within the paradigm of neuromuscular disease and looking for elevated carbon dioxide. And for sleep medicine physicians, unlike John, who don't have the same insight, what often will happen is you'll get a report saying a child has obstructive sleep apnea, and that's simply nonsense. And what we're looking to do is to try and come up with better guidelines to actually focus more on the carbon dioxide level, and then define what is a normal and what is an elevated carbon dioxide level. Because the criteria that are published by the sleep medicine board is exceptionally high, meaning that you have to have a very high CO2 at night to be defined as having hypoventilation or respiratory failure. And we're looking at ways to more accurately determine that and essentially use a lower threshold and look at some of the other values that are produced during a sleep study, because we ultimately want to identify respiratory insufficiency, respiratory failure as early as possible, and then treat it right as it's beginning.
That's a hugely important point. Thank you for saying that, because I definitely should have. So the definition of hypoventilation right now is 25% of the time with a CO2 more than 50, which is ridiculous. It makes absolutely no sense. It's yeah, and so what we often look at is. So yeah, we'll get a report and see that it's obstructive sleep apnea, but if you actually look through the sleep study, you'll see that a patient is breathing fast. They might maintain their carbon dioxide level. Our threshold 35 to 45 is more normal, and if it starts to approach 45, a little above, but a patient who's, say, a teenager is breathing 20 sometimes a minute, that's not normal. So their CO2 might be okay, but they're breathing really fast to make it that way. And then if you put a patient on Bipap, you'll see that the respiratory rate comes down, they seem much more comfortable. And there's something to be said for being able to truly rest your respiratory muscles at night, and also pressurize the chest too. So I think we need to do a better job defining hypoventilation, and then making it known in the sleep community, sort of similar to maybe neurology or pulmonary. Even though you're neurology or pulmonary trained, doesn't mean you're super familiar with some of these more rare disorders, right? And so it's the same thing in the sleep community too, that at sleep conferences, there are sessions on neuromuscular disease and what to look for. And so whenever we put an order for a sleep study to be done elsewhere, we always ask for a comment on the carbon dioxide level and the respiratory rate. Doesn't mean we always get it, but it's something that's really, really important to be done. And sleep studies done at an adult center probably are not going to have carbon dioxide monitoring. So that's another important thing if you're having it done close to home. And that's imperative. Without that, you may as well not waste the thousands of dollars and a restless or a sleepless night. So, yeah.
I just follow up briefly on that, just to mention that, and it's very important to also know that each condition, each form of congenital muscle disease really has its own natural history. So if your team locally is saying, oh, well, in Duchenne, this is not Duchenne. The muscles that are involved are different distribution of muscles, and very often it's the diaphragm, which is inordinately weak. But if you do your pulmonary function testing only in the upright position, you're going to miss the fact that when you're lying flat, or we say supine, that there's a massive drop in the pulmonary function. So we always tell our patients to ask their lab to do sitting and supine, so we can get an idea, because when you're in deep sleep, you're relying on that diaphragm. You don't have gravity to help you. That is a good index for us of when you need to go on BiPAP, because so often, as Hank knows too, we'll get these reports where we know the child should be on BiPAP, but the team is saying remove the tonsils. But then it's so hard to fight against a local team that's, fixated on OSA when there's, hypopneas and apneas because of a weak diaphragm. So I think it's also providing your local team with the knowledge we have, or linking them with us, because most likely your local team hasn't seen other patients with your particular form of congenital muscle disease.
Sorry, I feel like I fully recognizing that Duchenne is much different, but so the FEC around 60% is roughly where we start thinking about hypoventilation at night. But if you look at a sleep study, we start catching it when FEC is we looked at our average age or average FEC, and it was more like 90-something% that we start patients on BiPAP. So it depends on the definition, and unfortunately, you guys may have experienced difficulties with insurance too, right? So in terms of we can try to prescribe it, but we might have to really fight for it, and that's where going forward, if we have better definitions of hypoventilation for neuromuscular disease, that may help things too. So.
Okay. Okay, our daughter has call 6, and we were told to have a sleep study every couple of years for the settings on the BiPAP. When we went to the pulmonologist, he says, that's probably from pediatric pulmonology. We can do it with just blood test and sleeping with an oximeter. And so she says, no, we don't need a sleep study at all. Is there a difference on the approach from pediatric to adult? Some daughter's 20.
Yeah, adults have usually grown and don't keep growing, so. It's over time, it depends on the age of the patient too. So if it's more an adolescent or adult age and they've been really stable on good settings, then we might not necessarily change things. But over time, as a patient grows, your respiratory muscle function will change. Your thoracic architecture may change, which is a huge part as well. If there's any scoliosis in play, if it's progressing, then that can impact the pressures that are needed to adequately either pressurize or ventilate. And so you potentially can go a long time between sleep studies, and part of that's going to be driven by are you symptomatic? Are you tolerating your BiPAP at night? If you really don't like using it, maybe there's a reason. Maybe it's because the pressure's not right. Besides maybe the mask being an issue, things like that. If you're not having refreshing sleep, if you're still waking up with a headache, if you're seeing pauses, there are other signs that we go off of as well to potentially repeat another titration sleep study. But I guess I would say that in older patients, it is potentially feasible to not need to revisit the sleep lab, but in younger patients who are growing, you should revisit every few years, I would say.
Can I just add one thing to that? For the collagen 6 particular, we know the natural history of the condition, so as you age, there could be a requirement for higher pressure. And so we've seen our adult patients who don't do the repeat sleep study, they get right-sided heart strain on the echocardiogram, which is a sign that the right side of the heart is working harder to pump the blood to the lungs because the lungs are stiff. And that all normalizes once you optimize those pressures, so I don't know the exact interval between the sleep studies, but once every few years, I mean, I think there is a point in time in collagen 6 once you get to adulthood where things remain relatively stable, but I think between teenage to the mid-20s, it's still important to keep an eye on those pressures because our collagen 6 patients usually are pretty high pressures. Yeah.
And the other, Mimi brought up a good point that some patients are on an AVAPS mode, and that might sound familiar too, where you're sort of targeting a set volume, and that's going to change as you get older, right? Your lung volume's going to change. So we often use the mode, I don't know about you guys, ST, just BiPAP with a backup rate, and that will somewhat compensate for that volume issue. And there's some other there's somewhat center dependent practices as well. There's not necessarily a truly right or wrong way in terms of the setting, but that's another factor to consider if you're repeating a sleep study. It could be because of the volume that you're targeting as well is changing. So.
Yep, I guess my comment is on the national level for adult pulmonologists or adult trained people who take care of neuromuscular disease, we are using volume guaranteed modes. And unless the thorax is changing, then there is no need for another study. So that's why it's that way in adult medicine. And so it's a different approach. But I wanted to say about sleep is that, so as a non-sleep medicine trained person, and I don't read my own sleep studies, I rely on another colleague, I use other things to help me decide if a patient is having problems sleeping. And then a lot of it goes to what is reported. So in terms of having daytime headache, early morning headache is really important, feeling fatigued or getting more fatigued as your day goes on, not having a clear mind, not being able to do what you need to do during the day. Those are all signs that your sleep may be inadequate. And I often will get what is reported as a normal sleep study, or the sleep study shows obstructive sleep apnea, no hypoventilation. And then if you dig deeper, possibly there is. And so I think a lot of us here, the 4 of us sitting here, or 5 of us, all start assisted ventilation early because based on patient symptoms, because our markers of hypoventilation and breathing are really inadequate right now. And it's a big focus in the pulmonary community right now to have more sensitive pulmonary markers and more sensitive measures of pulmonary function. And that's something that's being worked on actively at this time.
A couple more additional points to muddy the waters further. So I take care of a lot of adults as well because we don't have great transitions of care, which I know is a whole conference in and of itself. I tend to use a lot of interview. So, what's going on? Are you having morning headaches, daytime fatigue? You kind of zoning out at dinner, falling asleep in your soup, that kind of stuff. And then data downloads. So your Bipap machines record every single breath you take as long as you're wearing it. And we can look at that data over time. So I can get data that's different than a sleep study, but over a longer period of time to see what's happening. And it takes a keen eye to know what you're looking for in that setting. The other thing I'd like to point out is that even if you have a sleep study that's normal, to try to come off of Bipap, that is one night. What about respiratory muscle fatigue over 2 weeks, 2 months, 2 years? Maybe you're okay that night because you've been well rested for the last 6 or 16 years, and now I took you off and you did okay one night. But that doesn't mean much for the rest of your life, right? That's one night. So I think a lot about removing respiratory support for years and then seeing what happens. I'm not willing to wait to just see what happens. So that requires a different level of detail that a sleep study can't show you.
My name is Caitlin Parker. My daughter has Lama 2. She's 3 going on 4 years old. We were introduced to Bipap during a horrible RSV stay in December. We were wearing it for 24 hours a day, avoiding a trach. We were successful, went home 32 days later with the Bipap. We went in for our first kind of evaluation with our sleep side of pulmonary care, and we're told that due to the data download and just our history of her, that she was doing well enough to not require a sleep study. Being that she's brand new to it, that we were introduced inpatient and they have a ton of data, she's never had a formal sleep study. Is this something that I should continue to pursue or leave it alone until we're symptomatic?
I think it would be a very good idea to assess her settings, whether it's during a sleep study or returning in the hospital to reevaluate how she's doing, simply because the way that the lungs and the respiratory system work when you're sick is a lot different than when you're well, and she may get by with lower settings. The one thing that I did want to comment on further is that oftentimes when patients start on ventilation, whether it's nighttime ventilation or daytime ventilation, they will say the following morning or during the day, if it's daytime ventilation, that they are breathing much more easily than before and feel much better than before. And I use that a lot when I evaluate patients in my office afterwards. And I don't routinely get follow-up sleep studies unless there's a new question or a concern. And I feel that I'm it's reasonably accurate to make an assessment based on how a patient's feeling, and if they're continuing to stay within their sort of equilibrium, for lack of a better term. I also think that if there's a change in the overall progression of the neuromuscular condition, that can also potentially be linked to inadequate sleep at night. And when I see that, then I'll often either empirically increase settings or refer the patient for a follow-up sleep study.
A child that's too young to have a vital force capacity study and needs a sleep study, what are the parameters, which are the parameters that you use as number of apneas and hypopneas to prescribe a Bipap?
So that's tough, because I think it's in part, it's not just the AHI and the OI necessarily. The AHI being the apnea-hypopnea index, so that's going to include obstructive component, so somewhere in the upper airway is closing partially or completely, and then central component, right, where the drive to breathe, the signal's just not going. It's not, so with, it's a muddy, it's not a clear-cut answer, and I wish I could give you one in terms of what's the threshold for starting. Definitely if the OI is higher, say, or even if it's mild, but the patient's really symptomatic and you know their diagnosis, you know that it's, they have significant diaphragm weakness that may progress, then you're not necessarily going to try like Flonase or Singular or medication management, but you might think more towards initiating Bipap. So I think it's in part just hearing to your point as well, just sort of hearing the history of the sleep complaints, the assessment of the weakness as well, just on physical exam too, and then seeing what the results of the sleep study is. Hopefully over time we'll have better data for hypoventilation for some of those kids to see what is their respiratory rate, what is their respiratory rate during REM sleep and non-REM as well, and then going from there. And if you may actually see, if you have a split night study where you start off with a diagnostic portion and then you introduce Bipap, you can see that that respiratory rate comes down really nicely. And the initial diagnostic portion, the obstructive apneas and whatnot, they may not be that frequent, but the overall, you're just sort of unloading the demand of the respiratory muscles. So I know you have follow-up.
It's okay. No, I just think that sometimes it's difficult because even within the same disease, like LAMA2, that's the main thing that I research, it's actually, we have a spectrum of severity, and sometimes we have child that only needs that Bipap like around 10, but sometimes we only have head control, and the patient comes with a complaint that having more chest infections, and we can only rely on sleep studies because we cannot have an spirometry, so it's kind of hard to decide.
Yeah, the spectrum of severity and when things start is also makes things really convoluted too. I definitely give serious thought. If I read an abnormal sleep study with mild obstructive sleep apnea, then I still give, and seeing the patient, seeing how they are clinically in terms of weakness, are they walking or not? If they have scoliosis, I give serious thought into potentially starting still. So,
I just want to make one non-sleep medicine comment about sleep studies, and there essentially are two pieces of information you get from a sleep study. You know, one is how do you breathe, and John mentioned apnea-hypopnea index, which is how obstructive sleep apnea in part is determined. And part of that is how synchronously you breathe. Is your chest and abdomen going out at the same time? And when it's not, that's a pretty clear sign that your breathing isn't quite right. And the question is that from obstruction or from respiratory muscle weakness? The other thing that you get from a sleep study is how well are you exchanging oxygen and carbon dioxide, removing carbon dioxide and bringing in oxygen. And that's really the only significant the most significant variable for patients with neuromuscular disease, because we define respiratory failure by an inability to remove the carbon dioxide your body produces and then bring in the oxygen that is needed. And so one of the things that we'll be exploring over the next year or so is whether we can distill it just down to using capnography. And that would open up the possibility of doing home sleep studies, which would better recreate the sleep pattern that you have because you're doing it in your own bed. But there are a number of challenges to do that have to be overcome. But that's something that I think in time will make things a lot easier.
And just to add real quick, just to prove the inadequacy of AHI and OI, and even in patients without neuromuscular disease, there are many phenotypes of obstructive sleep apnea in kids and adults. And you might see patients with hardly any AHI and OI, but they're really symptomatic during the day. And you still treat them, and they improve greatly. So there's a sleep study is not the end-all be-all by all means.
I just want to add, my dream for the pulmonary field would be able to do a split sleep study when I know my patient has a really low forced vital capacity. But I think what I've encountered a lot when I tell parents to recommend that or ask for that, they get a flat no. They need to do a plain sleep study, return 3 to 4 or 5 months later for the split sleep study. But if I guess my question is that possible to go move the field towards just have half the night off BiPAP, half the night on BiPAP, and then just see the proof that they improve?
Yeah. We definitely do it, and it's somewhat age dependent as well. So younger kids might not tolerate, sleeping overnight and then all of a sudden a mask in the face with pressure blowing in, right? As you could imagine. Supplemental oxygen, we don't recommend that, right? For neuromuscular disease, that's not the answer, but that might be better tolerated for another population. So it is possible. I think it's possible in older patients. If you have a really high suspicion for sleep disordered breathing, I think it's not unreasonable to try BiPAP. The other issue that comes into play is then essentially you're getting a few hours a night of diagnostic time, and then you start the pressure. And so that means if you're sleeping 8 hours a night, you get 4 or 5 hours on pressure to try to figure out what the right setting is. So there is potentially a chance of not finding the right pressure when you're doing a split night versus having the full 8-9 hours of a study to try to figure it out. There was something else I was going to say that escapes me. Okay.
So at the risk of disappointing or angering my sleep colleague, I'm going to offer a slightly different way of doing things, which is much more clinically based. So if you're going to do a split night study, I think that is a viable option in a lab that can do it, but it also introduces a mask onto a child or young adult exactly at the point where they're least likely to tolerate it, which is when they're unconscious. And so we do a lot of preparatory work beforehand in the clinic if we ask for that. We fit the mask, we start some gentle air pressure in the clinic just to give the experience, and then we use child life a lot as well. So if you're going to have a split night study or a titration study, there is a lot of preparatory work that has to go into this. I'm speaking to a room full of parents. You know what it means to change anything in your child's life. But the other idea that I use sometimes is PAP nap, or positive airway pressure nap, in the clinic. So bring patients in, put them on a device, and watch them, right? I can examine a patient's chest. That's in fact all I do. And so I can see the difference between them laying down awake or asleep, breathing without support and on support. And we can change settings gently, slowly, and get to a reasonable point where we think we're inflating the chest and getting good gas exchange. And we monitor oxygen and CO2 levels at the same time. So we can do that in the clinic and get a decent sense, and maybe either offer the sleep lab a starting point so they're not starting from scratch, or just, in some cases I will say, you live too far away, there is no sleep lab near you, let's try this, I'll get a data download and you'll tell me how you're feeling, and we're going to follow this very closely. So that's a very different way of doing this than the sleep lab. And I have a 7-state region that I cover. Virtually none of my patients outside of the Denver metro area can get to a pediatric sleep lab, and certainly not one that does this complexity well.
My name is Barbara Shelley. I have a 37-year-old son with SEPN1, and my question is there something beyond BiPAP? He's been on BiPAP since he was 9. He has very poor quality of sleep.
I'm just trying to think if there is, in terms of just nocturnal ventilation, nothing is coming to mind, but maybe Oren is more.
So there's BiPAP and then there's BiPAP. It's all about settings. And so this is where I would use a clinical titration, just bring patients into the clinic and say, what feels good, what doesn't feel good, let's tweak this, let's tweak that, and spend hours doing that. John mentioned it a little bit earlier about different kinds of ventilation, and he said the words AVAPs, or average volume assured pressure support. I use that relatively frequently because it seems to be a mode that adjusts to patients rather than them having to adjust to it. But it takes a fair amount of expertise to know what, because there are more variables in that mode, it takes an amount of expertise to know which variables to tweak and why. So there are different things we can do. This is also a good argument for a sleep lab titration, although it sounds like he's been through that a few times.
So what I want to say is that families often remind me that the individual isn't just their diagnosis, right? So there's a lot that goes into sleep, and besides just breathing. And so with your affected loved one, it may be that there's something else that's affecting the sleep quality that's not breathing. And so at many sleep centers, there's sleep psychologists as part of the team as well. So I would advise that to think outside of breathing sometimes, and there might be other things that's affecting sleep initiation or falling asleep, maintaining sleep, or waking up early that may not be related to the breathing. But of course, for this population, we say first thing you should assess is adequate breathing while asleep, but there are other things that affects a person's life besides besides the lungs.
Yeah, I completely agree. And then there's limb movements at night can also be disruptive. So, and BiPAP may or may not help that. There are definitely different modes, of course. I was more thinking of if there's anything surgically. There's really not. So I think, unfortunately, yeah, there's BiPAP and there's BiPAP, and I think there's still BiPAP. So I don't think there's anything in terms of like a diaphragmatic pacer or anything like that. There's nothing else that really. What's that? Yeah, or tracheostomy too. But.
I just want to add to that, though, for SEPN1, it's a diaphragm which is inordinately weak, and so it's really going to be, I think, a necessity to make sure the pressure is adequate if sleep at nighttime is uncomfortable, just based off the natural history. And most commonly, tracheostomy is not necessary, especially for SEPN1. So I think optimizing the BiPAP would be, as everyone said, the way to go.
Hi. I'm Sarah. I'm an advocate, a Titan advocate for people with Titan-related variants, and I just wanted to see if you could, these may be three different questions, which is common pitfalls I see with pulmonologists or respiratory management professionals who don't have experience with neuromuscular disease, and I would put them into three different categories. One is the non-introduction or non-use of airway clearance. The second is what is the role of Cpap in this population, or misuse of Cpap? And then also the role of oxygen and its use in our families. Thank you.
As to the first issue, I think the single biggest flaw and inconsistency in care between people who have experience taking care of patients with neuromuscular disease and people who don't is airway clearance. I think it's even more of an issue than recognizing when mechanical ventilation is necessary. There are ways to assess for whether your muscles are strong enough to cough effectively, but the problem with those measurements is that they're usually made when you're well and in the office and don't necessarily reflect how things are when you're sick. My approach has been to implement the cough assist early before there's a clear need. For a couple of reasons. One, there's some potential benefit in doing range of motion or deep breathing exercises to help maintain the flexibility and function of the chest wall. And the other issue is that it gets the patient used to using the cough assist, and you as the parents used to administering it, so that when it's needed more frequently during an illness, you're much more likely to be able to do it effectively. And then the other issue related to that I always tell my parents to think of is that we without neuromuscular disease know that we're getting sick when we start coughing and sniffing and blowing our nose. And it's important to bear in mind that patients with neuromuscular disease can't necessarily do that. They can make movements that look like coughing, but it's going to be a largely ineffective cough. And so I think as parents, it's critical for you to recognize when something's changing. And then assuming you have the cough assist, then it's important to implement it as early as possible in a developing illness. The other thing that I would mention is once you have a level of comfort in using the cough assist and assessing your child when they get sick, when you're in the care of a medical professional, if they're not familiar with what's needed, you need to educate them. And if they don't listen, you need to educate them and be persistent and be what I like to call a difficult parent, which is really a parent who's advocating. And that's, I think, there's no way to educate every physician that you may come in contact with, emergency physicians or general practitioners. But if you come from a position of knowledge and experience, it often can work quite well.
So a little bit more on cough and airway clearance. Pulmonologists are infrequently encountered by neuromuscular disorders unless that's all we do, and yet you're encountered by it every single day. You are the subject matter expert, even in the face of a trained adult or pediatric pulmonologist. My colleagues are used to thinking about airways disease and cystic fibrosis and all these other things which have really no bearing whatsoever on anybody in this room. And so they think of an airway clearance impairment as mucus accumulation and the airway malfunction where the microscopic hairs, the cilia, don't beat in an orderly fashion to get mucus from far away to closer to the mouth where they can be coughed out. That's one set of problems that really isn't relevant here. So we have to show our medical professional colleagues that there are two different types of airway clearance impairments. One is what you usually think about where you get a vest and you get nebulizers and all that stuff. And the other one is I can't cough. And if we just think about I can't cough, I literally say this to my colleagues, there's a machine for that, right? I can't cough and there's a machine for it. I need a t-shirt. And if we start talking about function, right? I can't cough and there's something that can help me with that. You just get straight to the point. As opposed to trying to improve ciliary function, wear a vest and all that kind of stuff. That doesn't really address the primary problem. So we just have to tell them, I can't cough, okay? Cpap is continuous positive airway pressure, one pressure all the time. That's used to treat obstructive sleep apnea and keep the upper airway open so that breathing can happen on top of that. The problem in neuromuscular disease, in some types more than others, but in all to some degree, is that you can't take a breath. You can't expand the chest, right? Cpap doesn't help you do that. Bipap really is that low pressure to keep the chest open a little bit and then support for the work of breathing on top of it.
And I want to address the oxygen, please. So I guess the reason, one of the messages a lot of community members get is that oxygen is evil in patients with neuromuscular weakness. I wouldn't say that oxygen is evil, but that's not the first thing you should go to if a person who's weak cannot breathe. The first thing you need to do is help them breathe. And so the first thing to do is not CPAP, it's to help them breathe with every breath, what Oren just said, which is that you do bi-level support, which means that you have some pressure or some volume that's helped with every breath you take. If that is not enough and you have an acute illness, such as a pneumonia, then there is a role for oxygen temporarily, okay? But what happens is the first response when you're in an urgent care center, in an emergency room, calling an ambulance to your home is to put oxygen on the patient to get them stabilized. That's okay for a couple seconds, but you need to have a plan to start assisted ventilation or assisted breathing.
And the reason for there too is you need to blow off your carbon dioxide. So oxygen could just be a Band-Aid. So sure, 100% sats, but check a blood gas and the CO2 is climbing. And that's where Bipap comes in. Seconds. It's not, yeah, I wouldn't leave a patient on just oxygen with neuromuscular disease for a long time. So yeah, it can be fast.
So again, so when addressing, so the question was, why is oxygen not good and how long is it okay to use it? The answer was seconds, because the CO2 can start rising almost immediately thereafter. Again, I focus kind of like Mimi on medical education. So how do we communicate to other providers what is needed? And again, I just go down to brass tacks. I can't cough. The reason your oxygen is low is because there's mucus in your chest. Putting oxygen on that doesn't do anything to the mucus. You have to get the mucus out. So cough assist and Bipap, right? Pressurize the chest, give bigger breaths, allow the mucus to come up either naturally with Bipap or assisted with cough assist. So I write in every one of my consults, the appropriate response to low oxygen is not oxygen, Cpap, or anything else. You must start cough-assisted Bipap immediately, period. I don't know who reads that, but that's the way I talk about it. I just go to, what is your problem and how are we going to fix it? No other theorizing there.
My daughter is 6 years old, Emily myopathy, NEB. She's been on Bipap since she was 2. And we recently had a sleep study with the HIAC biphasic QRS ventilator. And it was relatively successful. SAT stayed up, CO2 didn't go up too bad. And right now the plan is, once we can get in the home, to use the HIAC when she's healthy, and when she's sick we would maintain the Bipap for the pressures. I just wanted to get your opinions on the HIAC machine, if it is a reasonable option to Bipap, especially when they're healthy.
So that everybody knows what we're talking about, the HIAC is what they call a QRS ventilator, and it's an interface that looks like a turtle shell, the top of a turtle shell that's positioned over the chest wall and abdomen, and then it's strapped around the back so that it seals properly, and then it's connected to a pressure source that applies pressure, suction to pull the chest outward, and then applies pressure to have the chest settle back down to the resting volume. And so it supports ventilation in that manner. I think the biggest challenge in using it is that, unlike Bipap, there's no way for a patient to synchronize well by demanding a breath, which is what you're able to do when you're on Bipap. Some people are able to tolerate it well, and it does quite nicely, in part because it isn't applied over the nose, and so it's not widely used, but when if it works, there's no reason not to use it.
Hi, my name is Mohammed. I have a 14-year-old son with collagen 6. So my question relates to scoliosis, and as that angle has progressed for a lot of these kiddos in this age group, they recommend surgery. So is there a threshold? What is the data behind intervening versus non-intervening? And what are our data after the intervention has been done in terms of lung function improvement? This keeps coming up. So it's always like an uphill battle with the ortho guys when you're talking to them, because they just see scoliosis and they want to intervene, and it's a life-changing surgery. So this decision, and then a lot of the collagen 6 kids have this progression during the teenage years, which is missed. So Dr. Foley had introduced us to Bipap recently, and we have this coming up. So I needed the panel's idea on scoliosis specifically with pulmonary function.
Scoliosis is not going to ever make pulmonary function better. Well, I say that both for patients who have scoliosis not because of neuromuscular disease, and even more so for patients who have scoliosis because of neuromuscular disease. Simply, you still have your neuromuscular condition. And so you're never going to see an improvement of significance, but you can see an attenuation or a decrease in the rate of decline if you're able to stabilize the chest wall and spine. There's some approaches that allow you to do this earlier than when one might do a spinal fusion. There are growth-sparing devices like the vertical expandable prosthetic rib or magic rods that can be expanded over time so that you can stabilize the chest and spine early and not fuse the spine.
And your experience with vertebral stapling, you know, that's a newer technique, I think, at Children's in Philadelphia.
That not done widely. It's, I don't think, as reliable as doing a rod implant, an expandable rod implant. We're not doing it very much.
Just one addition with the scoliosis bit, I definitely agree. It's not necessarily going to improve lung function. Sometimes with scoliosis, you can have impingement on an airway as well, and so you might have actually obstruction. And so fixing the scoliosis while having sometimes a bronchoscopy before and after, or intraoperatively, you can assess to see if there's any airway impingement, which could potentially, if there is impingement, it could lead to retainment of the secretions, and cough assist might not be as effective, things like that. So that could be an added benefit from scoliosis surgery too.
Just been asked to close up with two comments that Rachel asked me to cover. One is using nebulized medication. Obviously, neuromuscular disease is not asthma, but asthma medicine can sometimes be helpful, like albuterol. There's another medicine that we borrow from cystic fibrosis to help clear airways, and that's hypertonic saline in concentrations of 3 or 7%. And what that does is that humidifies the mucus and makes it a little easier to clear. It's very effective acutely. It's not effective and not appropriate chronically. So if your children are ever in the hospital and hypertonic saline is started when they're sick, it should not be continued long term unless there's a very clear reason, because what can happen is it can actually cause your child to produce more secretions, which then means more need for airway clearance. The other topic that Rachel asked us to comment on was signs of hypoventilation. There's some general, very non-specific signs that really speak to inadequate sleep at night. One is waking up and feeling tired, which is sort of a no-brainer. But the other is if you have high carbon dioxide at night, the vessels in your brain dilate so that the brain can get rid of carbon dioxide, and you often will wake up with morning headaches. So morning fatigue, morning headaches, morning bad behavior for little kids. If you can tease that out of their normal routine, those would be sort of general, non-specific, but I think useful signs to track for nocturnal hypoventilation.
Our goal would be to be proactive and not wait until we see those signs, because some local teams will say, oh, you don't have any signs of hypoventilation, but indeed the patient's already hypoventilating. So if you have those signs, as Hank said, you're definitely hypoventilating. But I think you don't need to wait for those signs. I think being proactive and not reactive would be probably the ideal scenario.